Andrea Baas. I'm a psychiatrist, and this is Sarah, who's an advanced nurse consultant. We've been working together on Equally Well in Southern Adelaide Local Health Network for the last few years. And what we're really presenting on is kind of the journey so far. It's very much not a finished product, even though we've been doing it for a while. And so it's really kind of an update about very much how we've been trying to do it at a local mental health division level. So we're in Southern Adelaide, so south of the city, it's kind of our catchment. Flinders and Noarlunga Hospital are our main hospitals, but we've got community mental health teams around that as well. Just skip over that. Welcome. So one of the things that we just wanted to point out that for us, we felt that the Equally Well approaches actually integrates really nicely with our local health network strategic plan as well, which is around striving for exceptional care, working together to improve health and wellbeing, with values around empathy, trust and inclusion, and priorities around equitable services and quality care. So this is kind of an example. This is kind of summarising where we've been at on this journey. So obviously we'd all know that SA Health signed the consensus statement a while ago. About 2019, we were approached from the Office of the Chief Psychiatrist, their advanced nurse practitioner, who was trying to look to start to embed Equally Well within Adelaide, and identified at the time the community mental health teams with the psychosis teams, so the kind of the longest stay community mental health teams within SALHN as the project site to kind of work on that. So she came and worked with us in about 2019 to develop an action plan using the Equally Well templates, and we developed an action plan based on brainstorming with a variety of staff in that in those teams. What we found, and we kind of quickly thought about it, we thought, well, actually, this isn't just longer-term community mental health teams. This actually applies to all of our division. So I took it to our mental health division executive and talked to them about the fact, you know what, this actually kind of applies more broadly. And we did get some executive buy-in to try and sort of roll it out across the division. From that, we started up a working group with representation. And I think kind of to note, unlike the New South Wales people, this is the first time we've ever tried it. We had no academics and no knowledge of implementation science whatsoever. So it was us just kind of working it out as we went along. We did get a working group up with the teams across the different parts of our division, people who are interested, and they came along and we kind of shared ideas and we talked about kind of what we were trying to do. Obviously that was kind of COVID as well, so there was kind of various ebbs and flows. I think we looked a lot about COVID vaccinating our consumers at one point as well. And so we had our first action plan and we did that for a few years. And then we've been able to really review it when Sarah came on board about 18 months ago. And so with Sarah coming on board as an advanced nurse consultant with a kind of focus around Equally Well and GP liaison, we were able to kind of refresh and review what we were doing. So from that, by that point, we still had some people who were quite well engaged in the meetings and discussions. We'd lost a lot as well, and it ebbed and flowed with kind of demands of other things as well. So this is very real world, I have to admit. We were able to bring together all the people that were still really engaged. We ran some workshops with them about really, you know, what's working, what's not, what do we want to do in the future, how can we kind of get there, and did some real brainstorming and mapping around that process as well. We also surveyed a whole lot of staff about, you know, what do you know about Equally Well, how are you doing it, what do you think we could be doing differently, and we sort of got some feedback from staff as well. We re-engaged with our mental health executive as well, and we also talked to our leadership teams as well. From that, we kind of rejigged the governance and the frameworks around it, and I'll talk about that a little bit more, but one of the things we found to try and embed it into our local division was we kind of needed that leadership champions in there as well as the staff on the ground, and we'd had a bit of a mismatch from that as well. So what we put in was an Equally Well steering committee for our division, where we specifically asked for people with a degree of leadership involvement to be able to be part of that, so that they could bring it back to their teams and support it. And then we put underneath that a working group with quite a broad membership as well, which we'll talk about both of these in a little bit more detail. And we aligned these to make sure we were really drawing on our local champions and the people with the enthusiasm around it as well. We also tried to just put some structures, to try and put some structures around it as we refreshed it. We also really tried to tie it into accreditation standards as well, and just to kind of make meaning within the whole of the division. One of the things we'd found was it sort of sat a bit separate and no one quite knew how it interacted with everything else, and therefore it kind of dropped away a little bit. So we've had a Equally Well action plan. We've had a refresh of that, and I'll show you that in a minute. We presented that to the standard committees. At that point, we had standard committees established, and we were making sure that we were sharing evidence-based presentations with the meeting chairs as well. So there was a really nice feedback up. Became an agenda item on the comprehensive care meeting, so that it was always being discussed there. And we had, internally, we working groups were providing summaries to the steering groups, and then Sarah and I are providing sort of every 3 months or so a report up to our mental health executive within our division as well, to just kind of keep showing that oversight of what's happening as well. There's been a lot of work within some of the teams to capture what they're doing on local standard boards. Some of them are even capturing on their daily huddle boards as well. So what are we doing that's progressing equally well, or the theme of the month as well. So there's been some really nice uptake within services to really kind of focus on that and talk about equally well as a focus of quality improvements across the division as well. We're also providing, and within the time that we've been running, there's now a equally well statewide meeting, updates provided there as well, and we're also providing updates to our community advisory group as well for our division.
Can I just do the mic?
Go for it.
I'm just going to ad lib as well. Before we really started to embed the framework, I did a search of the quality library, so all of the quality improvement initiatives, to try and be clear of our target audience of our local champions, and that worked really well. And I also linked in with the mental health, safety and quality health standard meetings in order to gain an understanding of the items and the champions that were being discussed. So we really did almost like a litmus test before we really began. Do we have the right people in the room? Are we accessing the right areas? And where are we doing really well, and where are there gaps?
Keep jumping in, that would be great. Thank you. This is how we work, you can tell. So this is talking a little bit more about our steering committee and also our working group as well. So again, it was that idea of the steering group. We had clinicians from each part of the service, and also that on the working groups as well. So I can see a few representations from some of our groups and from our division here this afternoon as well. And we really encourage people to join these groups, particularly the working group. We've kind of made it really encourage people to be part of that as well. And yeah, we've made sure that there's a really broad range of staff mixes as well. So in our working group, we've got lived experience staff as part of that. We've got rehabilitation support workers, we've got allied health, we've got nurses, we've got psychiatrists. We've got a really diverse group in that as well, and we think that that's kind of one of the keys. We think it's got to sit with everyone. It can't be a particular discipline's business. It's got to sit with all the disciplines within the staffing profile. So when we were doing our refresh, we had a look at our action plan, which by then was a couple of years old and a bit out of date, and we redesigned it and looked at it with our steering committee, and really kind of had to try and have a think about what did we have, and do we need to change it? Kind of quite pleasingly, the one that we took off as an action that we thought we'd completed was raising the profile of equally well within the division. So we thought we'd actually got to the point where staff are using that term, people know what we're talking about, people kind of see that as part of the business of our mental health service as well. So we took that off as a completed action. The other actions are, some of them have been ones that have been existing on the last one, but I think that's fine. So one was around comprehensive consumer-focused approaches to physical health assessment and care planning with all consumers, that we're engaging in regular and meaningful collaboration and information sharing with relevant stakeholders such as GPs, carers, families and support workers to improve physical health assessment and treatment with all our consumers, and engaging people with lived experience, consumers and carers, when we're developing and implementing new physical health initiatives that utilise trauma-informed and evidence-based approaches. And I think that's showing also that for us as a division, I think we're all still learning how to do these things. We're learning about implementation, we're learning about co-design. We're all kind of on that journey, and it's us saying that, you know, we're not at co-design with academic support, we're just really at the beginning of learning and we're doing it within our own resources. So we're just kind of acknowledging that that's kind of where we're at and what we're working towards as well.
Can I just speak to the beautiful coloured sticky notes? So it might not mean much to people in this room, but when we think about reward mechanisms, I went to Officeworks and bought some pretty colours. What a difference it made. Each colour delineates a different kind of service and how they thought they were doing really well currently and what areas they had to improve on. And as you can see, the left-hand side is how well they're doing currently, which was a really good validation for the understanding and the comprehension of equally well.
And the different colour stickers represent that we did get fairly good representation across the division as well. So this is our action plan, our current action plan till November next year. And we've put in a mission statement, so we've kind of looked at lots of different examples and then decided that this is how it was going to land best for us. To ensure, so we've got a mission statement about the equitable access to treatments and interventions that are addressing equality and diversity. And then underneath we've put in some action items that we thought we were a little bit more able to kind of measure and review against in a little bit more kind of robust way as well. So that's where we're sitting with that action plan at this point. This went through our Equally Well Steering Committee and then went up to our Mental Health Division Executive Committee as well. So it's been endorsed by our division as an action plan. And then I'm going to hand over to Sarah, who's going to talk about some of the practicalities. Thank you.
So as you can see, everybody likes a pretty picture. One of the pictures in the top right-hand corner is a picture of some outdoor physical health equipment currently in our Trevor Parry Centre. We've put this picture in here because it's a really good example of a key target area in relation to the implementation of physical health strategies. That's just one example. And the challenges for our consumer cohort to access relevant opportunities. We were very fortunate enough to have some funding and so purchase some outdoor equipment to make a sustainable approach within our clinical area. And the picture underneath is just an example of one of our quality boards. I'm aware that Carlin's done some quality boards as well. I think that's a really good sustainable approach. These run with a monthly planner, which we'll show through some of the other slides. And it's based on psychoeducation and evidence-based literature. The aim of me demonstrating these things is really the integration of the early mortality risk factors within the mental health cohort into everyday care planning, and some successes we've had around our multidisciplinary reviews alongside enhanced partnerships with the local GPs and some training initiatives for all staff across our relevant areas. And there's an expectation that the members that attend the working group, of which some of these items have come, these quality improvement items have come out of, share it with their teams. So to have an action plan wasn't enough because it's an ideal philosophy. And as we had so many different clinical areas with, as you could tell from our various sticky notes, different areas, different skills, different models, different length of stay. We really wanted to be able to engage those in the steering committee from the different clinical areas to identify some implementation plans. So the implementation plans sit at a local level and they're driven by the local leadership in order to demonstrate some effectiveness against each of the actions. So this is what happens when you are opening a mental health rehab unit and you ask a nurse to do a presentation. You get stretched things on a screen. So the first example that's really stretched is an example of one from our inpatient unit, which essentially tries to show that their implementation plan against action item number 1 that talks about comprehensive care delivery to all offers to all consumers talks about an expanded MDT workforce that comprehensively addresses physical health assessments, whereas the one on the right-hand side, which you'll probably be able to see a little bit clearer, is a very different implementation plan. I wanted to show the contrast because in that implementation plan, it simply talks around strengthening and auditing our equipment, because sometimes simple fixes and things have the biggest impact, and each area chose their own goals.
And I think that's the thing. We had those actions, but then we asked each individual team, so not all of them were that big, to then identify that they wanted to work on. So we're really trying to pick up on the teams, what the teams saw as priorities and things that they would be able to action.
So we established a working group. There was champions from each area. Andrea's talked about that somewhat. And the aim was to incorporate physical health care and the risk factors into everyday practice across all disciplines and all relevant teams. We created a planner for 12 months, and the teams discuss and promote the clinical team. And again, this is my cutting and pasting. In the bottom right-hand corner is an example of membership local report, which you can't see very well. But on there is some consumer stories. We thought it was really important to pick up any impacts at a consumer level, not just theory. There's an example of the planner for the year, and as you can see, and we never really predicted this, but I was the presenter because I'm the chair of the working group for the large proportion, and then we knew we were getting a sense of success because we had volunteers and it wasn't just me. So that was fantastic, but you often have to lead the way first. So how do we know that we're having an impact? So as I said, not only did we have offers in the working group, but also there is an increased awareness and engagement across the services. We started to put regular items in the mental health newsletter. There was improved collaboration between teams, evidence of change. We've actually got some physical evidence of change and some quality improvement activities that are sent into us with ease each meeting. And I think the lessons learned are start small, celebrate the wins, build the champions, be flexible and expand the membership. The membership changes all the time, and we've got to keep reminding ourselves of what the purpose is. What's next? Have we finished? We're probably late. Do you want a summary?
Yeah. Right. So this is sort of where we're at the moment on continuing the journey. So we're really focusing on sustaining and embedding physical health into everyday care within our teams. Expand consumer partnerships. We know that what we've done so far is fairly staff focused, so we do want to kind of look to kind of expand into consumer partnerships more. We're planning to survey our working group again because we've nearly done 12 months of this. So we want to go back to our working group and find what they've found useful and not useful. What we've found for each working group just is that there's a presentation for sort of 10 or 15 minutes about the topic with some evidence-based resources, and then a consumer story, and then each of the teams provided a little update about where they're at against that particular one. And there's been some really lovely examples, like one of the community teams in their clozapine clinic, their nurses were keeping track of, all their staff actually, but particularly the nurses in those clinics were keeping track of, had they asked about, have you had your flu vaccination for every single consumer, and they were reporting that back daily on their boards, and then they were reporting it monthly as well. So we've been able to get a really nice sense of engagement and some sort of informal tracking. We'd love to try and figure out how to get some grants to support some of these and some partnerships externally as well. We're going to continue to collaboratively working across the divisions within SALHN, and also as the other LHNs are coming on board as well. So we're really excited to do some cross Adelaide LHN work as well. We have had the record for a while for the highest number of physical health assessments in the state, and we're planning to maintain that. We're going to
bragging.
no. We want to keep monitoring our outcomes in a fairly informal way that we're doing it at the moment. Ideally to do more, but where we're at the moment is this. In the longer term, we'd like to have a look at sort of how we could think about some research and aspects like that. But this is sort of where we're at on our journey within our division. So, right. Thank you.
Is there any questions for Andrea and Sarah? Go. Thank you.
Just a comment really rather than a question, but about how you've tied some of this into quality improvement work, accreditation and quality improvement kind of work, where the synergies with our project there, because actually our project came out of our statewide benchmarking discussions, which is an ongoing part of our process, and where people identified where we looked at practice in different areas, they identified this was an area that they thought we could do some quality improvement, and that translated then into the statewide project. So I think that is a good place to start.
Yeah. Thank you.
Listen, thanks so much. I mean, this is really inspiring. You can't get me away from the mic. And also because it's real, it's not this academic stuff. It's what you're doing in the services, and I just think it's so encouraging to everyone. My question is, what would one piece of advice be for someone who's looking to start this journey in their context?
I think it takes time and really build the reason for doing it across from the floor up to your executive. I think unless you've got that, it's hard anyway, but unless you've got that, it's not going to work. Yeah.
And just to add to that, I think looking back in hindsight, at the beginning of the process, when we were going through a review of the first iteration and moving into the second, it seemed like we spent a huge amount of time in that planning stage. And it wasn't until reflection, when you think about a change management model, that planning stage and taking your time to get it right and having that shared vision and having the executive buy-in was the absolute key, because sometimes when we felt a bit lost along the way, we've gone back to that because we've always had the right people at the table and the support.
Yeah, and probably don't be like me and only learn about implementation and implementation science last year. So,
and always meet, even if there's only 2 or 3 people, when the clinical pressure's on, because the minute you start to cancel, the vision is lost.